Ladies and gentlemen, your speaker today is Dr. Osama Al-Malt. I am a professor of surgical oncology at the National Cancer Institute, Cairo University, and my talk today is about colorectal cancer. And to start off, just to give you a brief description of the anatomy of the colon arches around the abdominal cavity surrounding the small bowel. The average length of the colon is about 140 centimeters, and its diameter varies, being maximal in the cecum and rectum, and a little bit narrower otherwise. It is distinguished from the small bowel by the concentration of longitudinal muscle fibers arranged into 3 groups of bands, and these produce sacculations and haustulation of the colon when they contract. The colon is composed of an ascending portion that is on the right side, a transverse portion, and a descending portion, and a sigmoid or an S-shaped portion. It finally ends by the rectal canal and the anal opening. The cecum, which is the first part of the colon, lies on the right side and has the appendix projecting from its apex. Colorectal cancer is the second most common malignant tumors in the US. This is in contrast with the low but increasing incidence of the disease in Japan and Finland and other parts of the world, where there is a higher incidence of esophageal and stomach cancer as opposed to colorectal cancer. And what is interesting is that people from Japan who move to the westernized culture tend to develop colorectal cancer at a rate similar to that of the Western cultures. Colorectal cancer affects males slightly more commoner than females. It is commoner in the older age group of patients, that is 60 years or above. In the United States, there has been a changing pattern of disease with a relatively rising incidence of disease in the right colon. In our country, here in Egypt, we are experiencing a different pattern of the disease, being relatively common in the younger age groups of patients, and that is about 20 to 30 years of age, and commoner in lower locations. We have an increasing incidence of rectal cancer, low rectal cancers, and we have a more aggressive type of disease. Predisposing factors to this type of disease are mainly benign conditions of the colon, such as polyposis or chronic ulcers. There has been some emphasis on some familial predisposition and on the relation of colonic cancer to chronic constipation and to certain types of food that predispose to chronic constipation, such as the high animal protein intake. Individuals who are not at increased risk and who do not have symptoms should be screened annually for the disease. This should consist of a digital rectal examination and an occult blood in the stool. That is, occult blood is that blood that does not appear in the stools. Some tight screening programs do advocate a colonoscopy, that is the scope of the colon, every 5 years. The clinical features of the disease are, in 75% of cases, they are vague symptoms of ill health, just the sensation of not being well, or vague abdominal pain or colic. And otherwise, the clinical features will depend upon the site of the disease. Whereas in the cecum and the ascending colon, they present with slight change in the bowel habits. Some patients will experience weight loss and weakness from chronic blood loss in the stools. In the transverse and left colon, the disease is usually annular, that is the constricting type. And so patients will symptomatize by gripping pain or progressive constipation. In the sigmoid or rectum, the passage of blood and mucus and diarrhea will be more frequent, together with tenesmus or heaviness during the passage of the acts. Mind you that as the disease progresses, it might cause complete constipation or obstruction to the flow of stools, otherwise what we call intestinal obstruction. Diagnostic procedures or colonic visualization may include either a high-quality X-ray, that is what we call a barium enema, or a scope, that is a colonoscope. These investigations should aim at defining the extent of the primary tumor and to exclude the presence of any other synchronous, that is occurring at the same time, lesions. Finally, they should obtain a biopsy from that lesion to confirm or not to confirm the presence of malignant disease. Other investigations, on the other hand, should aim at proving or disproving the presence of disease beyond the colon and to other parts of the body. And we emphasize on the liver as being the primary suspect number one. That is the primary site where cancer of the colon metastasizes. Treatment of cancer of the colon is primarily resection or excision of the affected part of the colon, together with the lymph node bearing area, and re-establishing continuity of the bowel by anastomosing the two cut ends of the colon together. Recently, with the aid of surgical staplers, that is, like the staplers that you staple the paper with, surgeons are more able to perform more difficult anastomosis with more perfection. Cancer of the rectum, on the other hand, they do pose a problem, as complete removal of the tumor might necessitate removal of the muscles responsible for control of the act of defecation. And in such a case, it might be necessary to divert stools from its normal pathway to an opening on the side, on the belly, what is known as a colostomy. And care of such stomas is now possible with the aid of collecting bags or belts. On the other hand, localized excisions of smaller and earlier lesions is possible with preservation of the integrity of the rectum. Cure rates, on the other hand, will depend upon the extent of the disease and on the site of the disease. Early stages have a better survival figures than do late stages, but the overall 5-year survival without evidence of disease in cancer of the colon will go up to 58%, to about 60%. This has been reported after curative resection. Finally, follow-up for patients is mandatory to properly pick up those patients who develop recurrent disease at the site of the surgery or at distant sites. Patients undergoing operation are being prepared by enemas for the operation, are better advised not to fast during preparation, during the repeated enemas. Now, as regards fasting during the holy month of Ramadan, patients undergoing the operation are being prepared for the operation by enemas or such like procedures for the operation. During the period of enema intake, it is advised not to fast during the month of Ramadan. Patients undergoing operative procedures, that is, undergoing major abdominal incisions, are also advised not to fast. Patients receiving adjuvant treatment, such as adjuvant chemotherapy, adjuvant radiotherapy, they are, in a way, they are advised not also to fast during the holy months of Ramadan. But patients having passed the operative procedure could fast even if they do have stomas or belts around their bellies. Thank you.